And I would like to introduce you our next speaker, Dr. Arseniy Yashkin from Duke SSRI. Dr. Yashkin has over 10 years of experience of working with survey and administrative data, including Medicare, health and retirement study, and many other large health data sets. His background is in the field of public health, health economics, and health services research. The presentation title is Incorporating Medicare Data in Aging Research, Expanding Opportunities. Please, Dr. Yashkin, you can start your presentation.
All right. So good afternoon, everyone. Today we're going to be talking a little bit about administrative health data. Now it does says Medicare, but Medicare is not the sum of all types of this data. There's other types of data sets that share the same structure, the same limitations, and the same advantages. For example, the Veterans Affairs has a data set which has very similar structure. So if you know Medicare, you can go into the Veteran Affairs data straight on. Medicaid also shares a lot of the features that we're going to talk about today, but we will concentrate on Medicare, since this is something that I see more and more often in reviews. And I'm going to also cover some of the problematic areas I have seen when reviewing other people's Medicare papers. Now, to start off, just let's go through what the Medicare program is. It's a social insurance program primarily for the US elderly, and it covers about 98% of the US population age 65 plus. So it's nationally representative of whatever you want to study as long as it's for the elderly. Now, it also covers other individuals who are disabled and have with ESRD, end-stage renal disease. However, as is, these subgroups are not nationally representative of their age group in the US population. So if I have a person of ESRD who is 55, that person is not representative of the 55 age group. If I have a person who is 70, that person is nationally representative of the age 70 age group. Now, keep in mind, disabled individuals and people with ESRD age naturally. So once they hit age 65, there's no need to exclude them from analysis, because now they're part of the age range of which Medicare is representative. Now, there's two basic groups of coverage that you can get. There's the traditional fee-for-service model, which is what you're going to be getting if you get Medicare data. This includes Medicare Part A, which covers inpatient services, and this is an entitlement. There's Medicare Part B, which covers professional services, but you need to pay for this. And this becomes important, especially if you want to look into people of low income. And then we have Medicare Part D, which covers prescription drugs. Now, to get Part D, you need to have both Parts A and B and pay an extra premium above that. So this is a little extra monetary burden involved. The second group of plans is the managed care model, also called Medicare Part C, also called Medicare Advantage, so several ways to call this. And this is a managed care, usually HMO plan, which includes Part A, Part B, sometimes Part D. The problem is managed Medicare plans vary from plan to plan. So you never know what you want to get until you look at the plan. Now, some of the pluses is Part C often also provides visual and dental insurance, which you're not going to get under the traditional model. Now, even though we talked about the parts of the Medicare program, the claims themselves are organized differently. They are organized depending on the source of the claim. This could be physicians, hospitals, skilled nursing facilities, outpatient facilities, etc. The one thing to really pay attention to here is durable medical equipment, which is very tricky, as we're going to see throughout this presentation. This shouldn't really be treated as a source in and of itself, unless you want to study things like vision aids, but as a supplementary source to the other claims for deriving proxies. Now, Medicare releases differ. Sometimes you will not get an inpatient and a skilled nursing facility file. Sometimes you get something called MedPAR, which is both of those sources put together and aggregated at the state level. So MedPAR is much less informative. And if you have the option, don't get MedPAR, get the original claims. And after 2006, Medicare Part D claims become available. You order them separately, and it's actually a fairly complicated set of data sets and sub-data sets linkable with each other. The most important information that you'll get is the drug names, brand and generic, dosages, manufacturer, and the day's supply. But there's a lot of other things available in there for more in-depth study. Now, another important thing that you will get is something called a denominator file. Now, without a denominator file, most of the claims you can get are fairly useless. I know that the MCBS survey has a tendency to not give you the denominator file with its claims, which makes things very, very difficult for analysis. But if you have the denominator file, it gives you important information such as gender, race, date of birth, date of death, which you definitely need. Now, the race variable is a little tricky because it does not fully correspond to our common understanding of race ethnicity. In fact, there is not a race question and an ethnicity question. There's just a race question. And it's mutually exclusive. You're either white, black, Asian, North American, native, other, and Hispanic. And this setup is valid for 1993 onwards. Before 1993, you had white, black, and other. Now, there's a large body of literature that says that not all of these racial categories are equally accurate. White and black are generally valid. And once you start getting into the other categories, they're not as good at identifying their ethnicity. So you cannot say that white people are not Hispanic whites, because some Hispanics will want to say, I'm Hispanic. Some Hispanic will want to say, well, I'm primarily white. You don't get the option of saying both. So some caution is necessary when interpreting race in Medicare. Now, it tells you the months that you were covered under which part of Medicare, A, B, C, D, some combination of the above, whether you paid your premiums or you needed to be subsidized by the state. This is a good indicator of being in a low income category. Recent years have seen people publish really complicated indexes to identify poverty in Medicare data. And these complicated indexes don't necessarily do that much a better job than this simple variable. Now, zip code of residence is not usually provided, but if you're willing to jump some hurdles, you can get the zip code of residence. This comes in two versions: in the denominator file, which is updated yearly, and this is not a very good way to track migration. But if you really try hard on your paperwork, you can get the claim level zip codes, which is what the doctor has on file when the claim is filed. Now, most data can be got from 1991 to 2017. Getting data before 1999 nowadays requires that you prove need to CMS. So it's not as easy. 1999 onwards, fairly simple to get. Those earlier years, fairly difficult to get. You can actually go earlier than 1991, but in the earlier years, analysis starts becoming quite a bit more difficult. There's two very useful addenda to the basic Medicare claims, and this is especially true for Alzheimer's disease. The first one is the minimum data set available 1999 and onwards, and this provides comprehensive assessments by actual medical professionals. So this isn't just a billing claim. This is a person with a medical education going in, seeing the patient, and making the assessment. Two versions exist, 2.0 and 3.0. They overlap to a large extent, but they do need to be crosswalked. It's not a one-to-one switch. Now, the data is pretty good, especially since it provides information on cognitive status. So there's cognition tests built into MDS 3.0, and measures have been developed for MDS 2.0 that allow you to derive a person's cognition status, which is important for the study of Alzheimer's disease. Furthermore, once you get an MDS file, that usually includes both Medicare and a Medicaid recipient of such care. And since most skilled nursing facilities paid for by Medicaid, that's a big improvement. So you'll be able to supplement the MDS with the Medicare part, but you won't be missing out on what's being paid by Medicaid, even if you didn't buy the Medicaid claims for that person. Then we have OASIS, which is something similar, but it's for home healthcare, which again is becoming increasingly important in Alzheimer's disease. But OASIS, unfortunately, is not as rich in data as the MDS. Everything there is much more simple. And again, you can link the National Death Index to figure out what the cause of death is. By default, Medicare gives you a death date, but not a death cause. Now, you got this wealth of data. What do you do with it next? Well, the next thing, it's good to identify the health trajectory of your individuals. Now, for most health outcome analyses, what you would do is you would exclude individuals living outside the US. And most releases that aren't survey linked have an indicator for this, because Medicare is a US-centric program. It's not going to pay for your healthcare in Germany. Next thing you want to do is you want to find the first and last year month that an individual had both parts A and B. Being eligible for Medicare doesn't mean that you paid for the plan. You could have other sources of insurance. You may not want to use it. So you got to look at this. Now, some people only have the entitlement, Part A. Usually it's a good idea to exclude these, but if you're studying hospitalizations, you may not want to. So this is a researcher-oriented question. Then you need to find the first and last year month an individual was enrolled in a traditional fee-for-service plan or a special type of Medicare Advantage plan that has CMS process its claims. Because if you don't do this, you won't have any claims from that individual in the database. Within these bounds, you also need to look, well, for how long did the individual stay in fee-for-service? Because you can switch in and out. Early on, after the introduction of Medicare Advantage, you could switch almost monthly. Now they make you stay at least a year, and there's official enrollment periods. But you still have to look, because just because you found the bounds doesn't mean that inside of those bounds you have good data. And the rule of thumb that I use, if a person spends 10% or more of his time in Medicare Advantage, then I don't bother looking at him. It's a rule of thumb. You will want to vary depending on your research question. After which you identify whatever outcomes you're interested in using a outcome-specific ascertainment algorithm, and we'll talk about those in just a little while. Now, a caveat is if you're analyzing mortality trends, you don't do the things that we said on the previous page. Because for mortality, you're not really interested in morbidity claims. You need to know when a person came in, what the person's age is, and when that person died. You will always have the death date. So if you followed instructions on the previous page, but what you want is national representative mortality trends, you're going to introduce bias because you're throwing out quite a few people. So if you want mortality trends, you don't need to make those restrictions, other than perhaps the people outside of the United States. It's not always clear what's going to happen with the body and how the death records are going to be treated. So in the case of mortality, don't do the restrictions. Just go ahead. You're going to have a date of death independent of which type of Medicare the person used. Now, we talked a little bit already about Medicare being a representative age 65 plus. A little thing that I noticed is if you're a demographer and you're using a fancy formula to calculate exact ages, you may very well get an age that's slightly below 65 at time of enrollment, like 64.92. Just be aware that this can happen. It will not happen if you use the age variable, which is in the denominator. But if you're using a demographer's formula, you may very well end up dropping too many people. So be careful. So another thing to notice is eternal men and women. Sometimes people get lost in the paperwork and they're dead, but no one bothers to record this and they keep on aging. And some people are dead, but their relatives would like to continue receiving benefits. So after 110, it starts getting a little bit suspicious. So beware. So what does a health trajectory looks? It looks something like this picture. So you become eligible at 65. This individual went into a Medicare Advantage plan at 66. So we have no data about him there. Then he switched to fee-for-service Medicare, where he stayed for the most part of a couple of years of Medicare Advantage jumps until reaching age 90. He switched to Medicare Advantage right before dying. This happens quite often, actually. Now, we can't say just yet why they did that, but we do see some switches to Medicare Advantage before death. So we can analyze health outcomes within the fee-for-service range, but we can analyze his mortality trend on this whole health trajectory. Now, next, we would like to identify some outcomes. How do we do that? Well, there's a wide range of variables available. There's diagnosis fields, and nowadays they come in two flavors, ICD-9, International Classification of Disease, and ICD-10. The switch off is 2015, so before 2015, it's only ICD-9. After 2015, it's only ICD-10. 2015 is half and half, so you got to be really careful of that year. And also beware, what you're identifying may change as the code version changes. So if you're following something over that switch over time period, you need to look, did something happen to your trend? Did it jump up? Did it jump down? Because the codes changed, even though the diseases they're trying to identify are pretty much the same. Now, we also have a number of procedural fields. These span current procedures terminology, healthcare common procedure coding, and procedural ICD-9 codes. CPT and HCPCS codes do not have separate fields, so they're found in the same column, something to be aware of. Procedural ICD-9 codes have the same trouble as the diagnosis ones, the switch from 9 to 10. Now, revenue center codes are a less detailed version of the information you can get from diagnoses and procedures, but they allow you to stratify the data in useful ways. For example, if you want to concentrate on emergency room care, you first use revenue center to identify emergency rooms, and then you go from there. We have physician specialty codes, which allow you to identify physician specialties. It also allows you to identify some things you wouldn't expect, like maybe this is an Indian Health Service claim. Maybe this came from an ambulance service supplier, multi-specialty group or practice, things like that. And finally, there's time unit indicators for very specific services that are built that way. And this allows you to study ambulance trips and anesthesia care. In fact, you can time the amount of anesthesia care that occurred, how far away the ambulance was. And this is very useful information, and it's derived from this little variable, which is kind of hard to see in a general code book. But it's there and it's useful. And finally, there's Medicare Part D data. The thing to remember about this is mostly concentrating on things that you get at the pharmacy, not things that the doctor injects into you, which would have a procedural or diagnosis code instead. Now, it's important to remember that Medicare is a payer for medical services, not a provider. So what you're identifying, right, this is not an electronic health record. It's an administrative claim record. You're identifying the presence of a bill with a diagnosis code or a procedure code, not the presence of the disease. It only captures episodes of care eligible for Medicare reimbursement. So there's a lot of ways to get into trouble. For example, Wheelchairs are covered by Medicare once every 5 years if you need a wheelchair for an inside mobility problem. If you need a wheelchair for an outside mobility problem, you're out of luck. It's not going to be there. And the 5-year period is longer than the usual 3-year rule for most durable medical equipment covered by Medicare. So if you're using an algorithm that doesn't take this rule into account, you're going to miss a lot of people with wheelchairs. Now, another example is Zasavax, the shingles vaccine. It's available 2006 plus. It's phased out in 2020. So the claims data didn't get there yet, but will. But the thing is, even though there's a code for it in the book, right? You get an ICD book and you'll find the code for this vaccine. It's not covered by parts A and B, but it is covered for part D, which very serendipitously also became available in 2006. So where do I look for this vaccination? Well, I don't look in the Part D records because it's administered in a doctor's facility usually. I look in the Part A and B files. So if you're just grabbing a book and running off to study shingles vaccinations, there's a lot of trouble that you can get into. So again, not designed for research. You need to be aware of coverage rules and limitations. That's one of the things you should do. Don't just look up the codes, look up what happened to the codes, how do they change, are they actually covered? If they are covered, how often are they covered? Look for billing errors. A good way to do that is 0 or negative payments. A negative payment usually means a refund, so a claim was done incorrectly. Do not assume that the rules are being followed, especially with things like anesthesia claims. Always look at the data first. You can use proxies for undercoded things like low vision blindness. There's some existing coding patterns which are well documented in the literature. For example, morbid obesity is usually coded before a bariatric surgery. So the coefficient you would get on morbid obesity is likely going to be protective if you don't know about this fact. So don't run off writing that morbid obesity will solve your life's problems. The bariatric surgery may help, but not the obesity itself. When we talk about Alzheimer's disease, there's a big problem with tentative or mistaken diagnoses. Again, the diagnosis goes in, but it doesn't go out. So if the doctor changes his mind later on and the real diagnosis goes in a later claim, the previous one is not going to go anywhere. So once a claim is submitted, it's there. But the doctor may change his mind, and he may have a reason to do so. You can get some multiple claims for the same service. Anesthesia is very famous for this. Both an anesthesiologist and his or her assistant will submit the claim for the same procedure. And you can count anesthesia time twice if you don't keep this in mind. And many times the ascertainment algorithms used aren't very good ones. Always look through the literature, see what people are doing, and especially look for algorithms which are validated against other sources. Now, for Alzheimer's disease, it's good to link diagnosis to cognitive function testing, either from surveys or from the MDS. And there's some methodological issues, right censoring, left truncation, differences and changes in coding and practices, introduction of new codes over time. Again, all things to look out for. Now, it's only claims data. So if you want other information, which we often do, like socioeconomics, education, you either need to get that from another source or use zip level data. Some health-related behaviors, like adherence to guidelines, are modelable within the data set, but most of the time you're going to have to get creative. And of course, you're missing out on Medicare Part C. Not a problem early on, but Medicare Part C membership has been growing over time. Some studies have been done. The most recent one I did, and it's sitting in review and not going anywhere. I guess the reviewers are asleep or have COVID. But within several diseases, we found that there was not that big a difference in prevalence rates for age-related diseases between Part C and the fee-for-service population, but there are plenty of demographic differences, so this is something to keep in mind. But even with all these limitations, Medicare claims and administrative claims in general provide excellent opportunities for studying aging, for studying costs, for studying burden, for studying geographic, racial, and ethnic distributions of all of these problems. For example, let's say we wanted to take a look at the distribution of Alzheimer's disease across the United States. Well, this is a fairly difficult thing to do unless you have nationally representative data. And here we were able to use the Medicare 5% sample to create some geographic heat maps. Now, I cheated on these and I made these a state level. You can make these county level if you're willing to accept some missing values for some counties and the range of legends getting quite large. So for something that's more common than Alzheimer's disease, county level maps are much more reasonable. And if you get 100% Medicare, you can definitely do county level maps. But this gives you a very easy way to see what's going on at a glance. So we can tell that for white Americans, now, by the way, notice that the colors are a little bit off across the legends. So they're consistent within each race, but they do vary between races. So within white Americans, mostly concentrated in the Old South. African Americans, also a good concentration in the Old South, but then Maryland is looking very suspicious. I wonder what's going on there. The other race, the race of God knows what, again, the most problematic race, because depending on the year you get it from, anything can be in there. Hispanics are sometimes included as other race and sometimes they're not. So let's skip that one. That's the most problematic one for interpretation. Asian Americans, we see some problems in the Northwest. Maryland, again, looking suspicious. West Virginia. Hispanic, well, Florida, no surprise. And then we have Native American, which is a fairly suspicious graph because there's not that many Native Americans spread out across the United States. So what we're actually finding there is Native American rates within concentrations of Native Americans. So usually if you had a map of reservations, you could map those on the one of Alzheimer's disease here and see why it's looking the way it does. If I didn't want to aggregate, I could also look at the time trends and see how they differed over time between races. So for example, here we can see a rapid increase in Hispanic prevalence after 1999. You can see which race has greater rates, which race has smaller rates, how this changes between males and females. Or you can even look at age-specific distributions by time period, which is the last graph. And this covers pre-reform Medicare, 1991 through 1998. Again, Medicare rules change. You need to keep that into account. 1999 through 2005, that's before Medicare Part D, but after reform. 2006 through 2010 is early Part D era. Then we have the late Part D era. And the last 2 years are pure ICD-10 codes. So we can see, and the age-specific distribution sort of matches the growth of prevalence that you see in the age-adjusted prevalence graph in panel A. So a lot of opportunity for being creative with Medicare data, a lot of things you can do, and a lot of questions you can answer. And at this point, I will answer your questions. Thank you.
Okay, thank you very much, Arseniy. It was really great presentations with so many interesting details. And I think we have time for just one question. So if anybody will have this question, please ask now, or if no, then I will ask my question. Okay, probably I will ask. What do you think? It's a question pretty, often you can hear from the audience. How long does it take to become the medium level expert in Medicare data analysis? Because it's complicated data set, and how long you think it will take to learn the basis?
The answer depends on whether or not you buy our book.
Great.
But really, it takes a while. It really does take a while. So if it's all you're doing and you're active in Medicare research and just Medicare research, 5 years has got you covered. Now, the problem is you can start producing analysis immediately. The data is fairly easy to start producing numbers from. Starting to figure out that the numbers that you're getting are a little bit problematic takes longer. So the more time you spend on studying Medicare analysis, the more problems you find with things you do, and the better you get. I would aim at about 5 years.
Okay, thank you very much. Great response. Thank you. So I think we can move forward